Brilliant. All right, I've got it sorted, I think. All right, thank you, everyone. My name is Roisin. I'm a clinical associate psychologist, and here today I'm just presenting my dissertation research on the analysis of perceptions of trauma-informed care and well-being of staff within Isle of Dogs NMHT, which is where I work, and I work in the complex emotional needs pathway. So I'll just be presenting the study that I conducted, some of the themes that came up, the findings, and some of the recommendations that have been to some degree actualized since the study was conducted. I also can't see anyone's faces, so if there's any questions, there'll be time for that at the end, but just to let you all know, I can't see anyone. So just as a brief overview of the study, I conducted a thematic analysis which aimed to look at staff's conceptualization and utilization of trauma-informed care. And how this may be impacted by staff wellbeing. And I basically conducted several semi-structured interviews with different participants within the Isle of Dogs Neighbourhood Mental Health Team, and basically had a look at their perceptions of their ability to facilitate trauma-informed care within practice and how this might be impacted by their overall staff wellbeing and how that could have been further supported. And I also looked at a wide range of different roles within the Neighbourhood Mental Health Team, so tried to keep it quite reflective as to the sort of general perceptions might be. So 3 kind of key themes popped up throughout this study, which was systems, communication, and knowledge. There were a lot of discussions around how different properties within systems within the NHS might diminish client-staff relationships or might make it quite difficult to facilitate trauma-informed care. And also thinking about the kind of resources that are actually available to support general well-being, such as at the time reflective practice wasn't really happening for staff, and different provisions that might actually be able to impact staff's ability to facilitate trauma-informed care, which I'll discuss later. And also communication came up quite a bit, so being able to both communicate trauma-informed care within teams and also within service users feeling confident in order to do so, thinking about how rapport was built, sort of language that's used, whether that being like sort of soft skills, and just also the ideas of verbal connection within the team, all acknowledging different ways in which trauma-informed care might be communicated. And also just general knowledge of trauma-informed care, so just including contextual holistic understanding of trauma-informed care, what that might be. It's quite a vague term. There are lots of different understandings of what that actually looks like, and also just general psychological medical model knowledge, and how that can be kind of applied throughout different roles and not just psychologically informed ones, which are often impacted by staff's own awareness and experiences. So more specific findings were that understandings of trauma-informed care were quite individualised, again, often depending on staff's role, previous experience, confidence, how long they kind of worked in the service, and also as different NHS services aren't necessarily completely standardised, how that could be a bit different depending on what service you're in, and how that can sometimes be a bit confusing if that sort of training or understanding of trauma-informed care isn't communicated in sort of a standardised way. There was also a sense of feeling quite ill-equipped to manage trauma and feeling more suited to refer clients to psychological services. Feeling also unequipped to ask those maybe difficult questions during assessments, feeling like that's kind of out of their scope of practice when ideally we would be assessing for trauma, as we know that's such a massive part of working in secondary care and the people that we work with. And sometimes when trauma is being flagged, staff are kind of reported that it's the best route possible is just to refer to psychology to have a more thorough assessment when that's not always necessary, especially when we don't know the full kind of formalization of what's going on with the client. And also kind of adding to that, staff were unaware of all psychological resources available. We have a complex trauma team, a complex emotional needs team, psychological therapy services, all different services that do work with trauma, but often there was a bit of confusion of where to refer these clients who were reporting trauma in their past, and how to kind of manage that. And additionally, trauma-informed care was seen less as a concrete approach to facilitate and was instead conducted in a more abstract sense. Again, lots of very definitions of what it could be. There was no sort of just, I guess, concrete, standardized understanding of what it is. And also when I was assessing people's kind of knowledge on trauma-informed care, like soft skills weren't really acknowledged, report wasn't really acknowledged. Those small little building blocks which can help a client feel comfortable to sort of showcase that trauma-informed care weren't seen as like building blocks of it, which I thought was quite interesting. Additional findings include that staff pressures really exacerbated these issues. Team network itself was considered traumatized, and there's limited scope to practice or apply trauma-informed practices within the system, and may feel deterred from trying new approaches if, when feeling exhausted, when feeling traumatized, much like our clients, that it can be difficult to try new things or feel comfortable in doing so if that environment doesn't feel safe. And just worried about doing things wrong with trauma can feel a bit of a touchy subject. So if staff don't feel confident, don't feel supported within the environment, their well-being isn't being uplifted, there was definitely sort of notation of feeling uncomfortable in trying these different things. And additionally, trauma-informed care training was not found to be mandatory. There are a lot of reports of being unaware of when or where to access it, and if it was being sort of advertised, it tended to be a very limited short notice. I had one staff member telling me it was about 2 weeks before they found out when the training was meant to start, and that made things really difficult when you've booked clients in advance. The idea of having to then rearrange all of that work can be quite difficult to feel comfortable in getting that training. So it just didn't feel the most accessible, and I think there could definitely be some work to be done there. So then, based on this, established some recommendations based on these findings. So at the time of the study, which was around autumn, winter last year, reflective practice wasn't being conducted in Isle of Dogs. So that was something that came up quite a lot. And we eventually did have reflective practice, but that wasn't face-to-face. But now we have consistent face-to-face practitioner. But at the time as well, there were discussions of maybe not wanting higher management involved in reflective practice just because it felt like a less of a safe space. Staff maybe didn't feel super encouraged to attend reflective practice, kind of again having lots of other responsibilities and feeling like that wasn't something to be prioritized. But since we've actually managed to actualize with consistent face-to-face practitioner, that's been helpful, and I think there has been hopefully a bit more of a growing attendance in that remit to hopefully support a bit more with well-being and to note that other staff members feel similarly. Improved pathway mapping. So due to all the bit of confusion surrounding psychological resources and referring people for trauma-informed support, I ended up facilitating a presentation to map out the referral process of psychology. So basically mapped out the different teams within TAP Hamlets, mainly in secondary care, but also knowledge primary care, to help increase that knowledge about what psychology professions can do and how that can, respond, can be helpful for clients who have experiences of trauma. Also would like to encourage an attendance of trauma-informed spaces to be further encouraged, such as this one, such as, I believe there's trauma-based supervision, I think every other Tuesday, that kind of thing. Complex emotional needs has a space every other Monday to help staff to kind of learn a bit more about working with clients that they might have a few additional difficulties with or don't have that understanding of that trauma and how to work with it. There are these spaces available, but when I conducted this research, no one really seemed to be that aware of them, or if they were, didn't really feel like they had the time to participate in them. So I think there definitely needs to be some way to help staff prioritize their own learning and feel comfortable in doing that as well. And then also general valuing of staff well-being. So again, since the study, there has been more well-being initiatives that have been disseminated amongst the wider team by emails, so different sort of well-being things that staff can access. But also I think it could be helpful to have more of a discussion of vicarious trauma and how that can impact staff, and to kind of maybe have a space to reflect on, the things that we hear, and not just about the systems that we're in, but also the sort of work that we absorb. Working in mental health can be quite difficult. And then in general, standardized training. So again, it is offered, though again, it always seems a bit confusing when that's happening. It seems to be offered occasionally, does not seem to be mandatory, and again, only advertised with limited notice, so it can be quite difficult to access. Again, ideally, it should be high quality, address all aspects of trauma-informed care, from contextual factors, soft skills, building rapport, which I think can also just be helpful in general when working with clients. And also should be ideally quite consistent, because again, there were lots of different definitions of what trauma-informed care can be and what that might mean. So ideally, we would have a general understanding of what that is. And I think it could also be really helpful to have and to learn within training skills to manage potential vicarious trauma. As staff, we also, deserve to have that space. And if we're able to kind of have those skills, or in using supervision, to be able to have that to be encouraged to speak about, I think that could be helpful to just build a bit more space for reflection. And in general, the idea of promoting trauma-informed care, so feeling that professionals should be empowered to utilise it. It's not just something for psychologically informed professionals, it's for everyone. And if we're able to kind of screen for trauma initially, that could also maybe help speed along referral processes if people are aware of how to refer different clients into different areas if they're aware that trauma could be impacting someone. Perhaps thinking about teaching basic formulation skills, helping staff to feel more confident and comfortable in utilising trauma-informed care. Because I think also in this research, a lot of staff members are using trauma-informed care, but kind of not realising that's what they're doing. So I think also just being able to build up that confidence could be really helpful in order to kind of build up those connections with service users. And again, this can be done by increasing awareness of trauma-informed care, encouraging staff to attend these spaces, engaging in standardised training, which does, I think, need to be advertised a bit more, and helping to support staff to just engage in these spaces where that can be facilitate this understanding, and also to allow for questions and curiosity, and just allow people to feel engaged and well enough to do so, and to feel comfortable in learning new things with an environment that is essentially fostering a high sense of well-being. I feel that staff could feel a bit more comfortable in trying new things or feeling more confident, and overall in general can help build up stronger relationships with clients. Thank you for listening. Sorry, that was very short and sweet, but happy to hear any questions or hear any thoughts. That would be really nice. Thank you.
Thank you, Kirsten. That's a great presentation. I think you managed to summarise something that I imagine was a very large, complex piece of work. So thank you for keeping to time. I'll let you manage the questions, but it looks like Elliot's got his hand up.
Am I okay to come in, Patricia?
Yes, sorry. Yes, please do.
Rashid, thank you. Really good. Really, really good. It's really good because it's good bit of thinking through, and it's very clear to understand. It's also very generalizable to probably many teams. Before I came to this meeting, I was in another meeting, and we were thinking about, if we were starting from scratch, how would we ensure that our services were empathetic? And that's not quite what your research covers, but there's probably some similar things that are going on. You've talked a lot about staff support, reflective practice. You've talked a lot about where people send people when they're traumatized. So I guess that one of my thoughts is, there's one of your early slides says there's something about something we do in the NHS that gets in the way of this. I wondered if you could say more about that, because if we were starting from scratch with a new team, how would we not put those barriers in place in a new service? It's a big question. But the sorts of barriers I imagine might be things like lots of forms to fill out and lots of, IT issues and all the rest of it. But I don't know, what were you hearing in the research?
Do you mean the current sort of systemic issues and what we would want to, I guess, not happen to sort of support that empathy? Yeah.
Yeah. So I mean, you framed it as trauma-informed care.
Mm-hmm.
Like having an understanding of the person. We could think of it as psychologically informed care if we wanted to, but that's just a different, wider lens. But in your one of your first slides, your general introduction, there was something about the NHS gets in the way, and I wondered what that something was from your conversation.
Yeah. So I suppose with those sort of systemic issues or the properties of the NHS that kind of get in the way, I think it is probably feeling like just a lack of resources in general, feeling there's not enough time, not enough space, feeling like there's a lot to do, feeling very, very overburdened with a lot of additional pressures. And I suppose somewhere like reflective practice is really helpful, but I guess can also only do so much when there are these material issues which aren't quite being met, and those sort of general needs aren't being met. And again, I guess looking psychologically, if those needs aren't being met, it's quite difficult, I guess, to access or to do that kind of high level thinking around these things. I think it does just generally come down to a lot of different pressures and not feeling maybe that safe or secure or stable within the roles. And just finding it quite difficult, I suppose, to try new things. But I think, if it boils down to it, it's lack of funding within the NHS, a lack of feeling like those resources are available to feel confident and comfortable, and to not feel overstretched and overburdened, I suppose, which I know is a very vague answer, and not a particularly nuanced one. But
can I just replay it, because I wanted to check? It sounds like you're saying something about a mismatch between the demand and the supply of people and things to help meet that. Something about a culture that allows us to learn things together, and something about psychological safety, where it's safe enough to try something, to take a risk, and it not be punished for taking a risk. Is that what you're broadly pointing to?
Yeah, that's a much nicer way of saying it, essentially. And also perhaps feeling a bit like attacked at times, depending on what service, from reaching those goals, those numbers, but not feeling comfortable, I guess, and maybe giving that extra time to utilize these sort of trauma-informed care principles and that thing. So
Thank you. Wonderful.
If I could just come in, because I think we often talk about, or there's a sense of trauma-informed care being another thing for us to do, and I think it's more another way of being. It's how we do things, and I think that's one of the misunderstandings that I often see, that it's a thing to do, ideally with people, but sometimes to people, when it's actually about doing what we do, but in a way that is aware of the history of people and what people are bringing. And Elliot, when you said, if we had a clean slate, what would we do? And I think one of the key parts of being trauma informed is recognizing what's come before. So it's almost like, can we ever have a clean slate? Because in fact, it will be populated by people who have got histories, and whether that's staff or service users. And that there is a comment in the chat about the workforce being traumatized, not just vicariously, which I think was recognized before, but also directly. So the kind of where are we starting from, even if we have a clean slate, I think it needs to be informed by what's gone before.
I completely agree. It's, thinking about asking, what's happened to you, as opposed to why are you doing this, and actually taking that time to really understand what's sort of going on with the person. So completely agree.
Angela's got her hand up, so I'll bring Angela in.
Thank you. I just wonder, first of all, thank you for presenting. And I was wondering if you, or probably you, and then maybe others can jump in, can say a bit more about what reflective practice really is, because I think that topic comes up, or like the concept comes up often in this group and other ones, and I don't know if everyone has the full understanding of what it looks like, how it can vary depending on the setting. I'm conscious that lots of people don't necessarily work in mental health services here.
Yeah, it's a very good question. I mean, I think reflective practice is often sort of like touted as the be-all end-all for NHS well-being, and that's not necessarily the case. But I suppose, and maybe someone might have a better definition than me, but just, I guess, a space to have like a neutral reflection about what's been going on, what might be troubling different staff members, and hopefully in that sort of group environment can kind of offer a bit of emotional support. It's not necessarily a place for advice or anything like that, or I guess it's a therapeutic style space, but it's not therapy. but more so as a space to kind of raise reflections and to really think about different things that might be going on in the team, and maybe sort of having a look at those systems at play and that sort of thing. But I don't know if anyone else has any ideas or additional reflections.
I think I would like to kind of add to that. I think it is certainly that there are many forms of it, and I think you're absolutely right that it's thrown around as a panacea to all challenges. My understanding and what I would want us to be doing is using that space of reflection to think about the impact of the work on our ability to do the work. So it's a circular process, this idea that we're within a kind of, we're constantly being affected by things around us, and including the world, not just the work. And that inevitably will have an impact on how well and able we are to look after and serve the people, whether that's a service user in a health system or a resident somewhere. It's really recognising that we're not automatons. We're not the kind of blank slate professional, that we bring our own histories and our own selves that are impacted by the wider world into the work, and our ability to do that. So I think it's a little bit more purposefully connecting and seeing this kind of iterative process of we are part of, we are as affected as we are able to affect, be affecting. That would be my take. Lydia.
Hiya. I was just going to, I guess, reiterate your point. So I'm speech and language therapist at Barts Health. So we have clinical supervision as a group every 6 weeks, and you're grouped with up to 3 other people who are the same level as you, and it's facilitated by someone more senior, but that person shouldn't have a direct line management role with you. So it could be someone from a different team or another manager within your team, but it's not your line manager. And we have quite strict rules about kind of what that looks like. So you get an equal chance to basically do reflection, and we use any of the reflective cycles that are available kind of online. But the idea is that the group is a highly confidential space for you to be quite open and honest about the things that you're experiencing, and that you, as the other group members, you would only ask reflective questions. So like you say, you're not there to provide advice. It's more just about, so how did that make you feel? So what do you think you're going to do next? Why do you think that happened? And I think for me, that's incredibly valuable in terms of the work that I do, and having somewhere that I feel I'm really held within my own team. I'm also very lucky to have just really accepting line management above and above. So I think that's also really nice, and knowing I can go to them saying, this is too much. I've had too much safeguarding this year, or, and being able to kind of flag up, what do we do when we have a high number of safeguarding cases? Because I can keep going to all the regular twice a year safeguarding supervisions. I can keep having my safeguarding training, but actually I've got so much. I notice you talk about that kind of vicarious feeling, and I think I work at London East Alternate Provision 3 days a week, and I think having the contrast between being there and then being in another school, I think sometimes it's very easy for them to forget just how challenging all of those kids are, and just how much tough, complex trauma is in that space. And I think that therefore me having that outlet within my profession is just insanely valuable, and that's something I would really like other settings to kind of put in place, because it does take time. It does require you to put that energy into it, and to bring something, to open up yourself, to be quite vulnerable. But I think for me, that's just been really, really valuable, and I just don't think I'd be able to kind of do the work I did if I didn't feel like I had that outlet.
Thank you, Lydia, for really bringing to life a slightly abstract thing. I think that's a really rich description. And I think sometimes it's seen as a additional luxury. We don't have time for this, when I would see it as being quite core to helping people carry on to provide emphatic care, empathetic and compassionate care. So thank you for that. I'm going to move us on because we need to give Callum some space to do his presentation. So it'll be a similar format of presenting and taking questions and discussion at the end. So I'll hand over to Callum. Thank you.
Fantastic. Thanks so much for having me. I'll just bring up my slides. Whilst waiting for those to come up, yeah, I can properly introduce myself. My name's Callum Campbell. I'm a civil contingencies officer, and I've been with the council for about a year, but I've been in emergency planning for probably 5 or 6 years with a background in the voluntary sector, essentially. I suppose what I'm hoping you're going to read from that is we've just had a very engaging presentation from someone who has a very intimate understanding of trauma-informed care. And now you're going to kind of get the other end of the spectrum. I'm not a trauma-informed care practitioner, and this sort of presentation has kind of come about from looking at how Tower Hamlets Council supports its displaced residents displaced by civil emergencies. I'll go into all of these terms in a bit more detail sort of shortly, and sort of retrospectively looking at trauma-informed care and mapping those sort of principles onto what we do, and looking at sort of areas where I can improve this and move more into this space, essentially. So, brief overview of the presentation. Yeah, we're going to talk about what emergency centres are. I want to give you an idea and understanding of what they look like, how they come about, and then also a very brief idea about what it's like to move through one or be a displaced Tower Hamlets resident attending one of these emergency centres. And then I'm going to look at the 6 principles of trauma-informed care and sort of try and look at the various different elements that we have in place in these emergency centres to try and support people through this space. There is a bit of a plug coming, so watch out. Feel free to switch off at that point if it is relevant to you guys. So, an emergency centre, I kind of slightly touched on this already, but an emergency centre is an umbrella term for the temporary shelters that us as the local authority will open up when there has generally been some form of displacement of our residents. The most common type of emergency centre, the one that I will largely be talking about and referring to today, is a rest centre. This happens when temporary shelter is needed. There isn't necessarily an element of criminality or evidence gathering that can be associated with the Survivor Emergency Centre or the Friends and Family Emergency Centre, where the police would run those. So we're just going to be talking largely about these rest centres today. They are shelters that open up within between an hour and 2 hours, and they can remain open for if we're talking about rest centres specifically, they might be open for 48 hours maximum. The main reason why they're not open for much longer is that they're temporary shelter spaces. They're places where people can get some information, people can have some food, access some hygiene items and some refreshments. But to have members of the community be sort of in limbo in these what is large publicly owned buildings, sort of shared sleeping spaces, it's really kind of not good practice to have people staying in those for 48 hours. So that's a kind of a hard sort of stop as to how long they can be open for. We've got on screen here some photographs of emergency centres that have opened in the past. Most of these are from exercises. Yeah, as some people are dressed sort of rather strangely, like with that high-vis orange jacket we can see there. They typically occur in, like I say, large public spaces. It could be, our idea stores within the council, but a lot of our emergency centres or our pre-identified or preordained centres occur in schools. So there's obviously an element of the timing, about how much impact that can have on sort of the host organisation. They're staffed by a mixture of council staff from across the council, quite often with a social care background. We have one manager who is in the emergency centre to support the welfare of all staff and all attendees, and they act as the kind of the focal point. They'll be liaising with voluntary sector organisations, with other blue lights colleagues, and they will also have our emergency centre officers who report to said manager. They are in charge of individual support, one-to-one support for displaced residents, people who have presented at this emergency centre, handing out refreshments, administrative tasks, and then also some of those general sort of practical tasks that would be associated with managing a kind of a public space, a temporary public space like this. It's also important for me to say at this point that this is not a medical space. It's not sort of, we can deal with some very minor sort of like first aid injuries, can deliver some first aid, but it's important that we recognise this is not sort of a medical space. So we've kind of spoken about emergencies. What sorts of emergencies are we talking about? These are all civil emergencies. So the most likely scenario that we find is it's fires. It's domestic fires, block fires, flat fires, people being displaced from those fires and from the sprinkler systems that become activated. We can also see on screen that there is the Bow crane collapse as well. Gas leaks is another quite large incident, or quite a regular incident that we might see. And I think it's important to sort of touch on these because with each different type of civil emergency, the people who will turn up at an emergency centre will come with a different sort of mindset or headspace with them. So if someone has been evacuated from a flat due to a gas leak, then people, generally speaking, are quite, frustrated to be evacuated, but are also quite happy that I know that my personal possessions, my property is not sort of at risk. Whereas if it's fires, it's quite a different space. It also means that at these different types of emergency centre, there can be varying degrees of trauma in them. So I touched on the survivor emergency centre. I think from the name of the title, you can imagine there is sort of quite often a lot more trauma in that space. So this is overly complicated, but it really kind of broadly just shows where or how the process goes to actually get an emergency centre sort of set up. So obviously you have the incident that occurs, that's your flood, your fire, building collapse, whatever it may be, and then sort of the blue light services, 90% of the time it's the fire brigade, get in touch with our CCTV unit, who then relay the call on to myself or someone like me in my kind of capacity as an on-call civil protection coordinator. And then from there, depending on the type of emergency, the nature of it, the scale, a few different sort of elements really, we will be working with either a kind of a senior humanitarian assistance officer, or as well as a local authority liaison officer. And then if this emergency scenario is set up, we would also be liaising with an emergency centre manager. The idea being that the SHAO comes up with or sort of runs vulnerable persons checks for us. So looks on Mosaic, our social care database, and interprets the results of Mosaic and lets us as a civil protection coordinator know, if there are any additional support needs within the kind of the cohort of affected people that we or the LALO, the local authority liaison officer, or the emergency manager should be looking to provide some extra support for. Okay, I won't go into that in sort of too much more detail, but the last thing that I'd like to kind of outline is sort of what happens when an attendee arrives at an emergency centre. So this should kind of give you a broad flavour of what it's like. And if we still stick with that hypothetical scenario of a gas leak, people are evacuated from their homes by the London Fire Brigade. Sometimes the police will get involved as well. They'll be given the address of this emergency centre. People will arrive, they'll turn up at reception. We always have these components in every single emergency centre. At reception, basic details of the attendee are taken. They are signed in, they're given a wristband so that we know that we've signed them in essentially. And then they're crucially asked, do you have any immediate needs? From that question, there's a bit of triage around the immediate needs that that are disclosed at that point. You know, sometimes there are some very immediate needs that need to be prioritized and are actioned immediately, and sometimes that's less of the case. From there, if someone has got immediate needs, we might take them straight through to registration, or where we basically get more information about the individual and try to sort of, you know, get them more information around how we can support them. Also, we recognise that there's sort of links back to our senior humanitarian assistance officer, making sure that we are providing additional support for any sort of identified as vulnerable people. And then, you know, typically in these emergency centres, it's a bit of a waiting game where you're in this kind of large shared space, accessing welfare support services, perhaps speaking to voluntary sector representatives, community sector representatives as well, and perhaps other branches of the local authority. So what I'm going to do now is I'm now going to look at each of the 6 key principles of trauma-informed practice, and just going to go through some of the areas in which they kind of relate to the kind of the process that we have in place for supporting people in these emergency centres. I'd also like to sort of say at this point that I feel that I can see the themes kind of shine through in our practice, and that is largely because this emergency centres plan is standardised at a pan-London level by the London Resilience Unit, who, just for the purposes, the meeting is a kind of regional resilience planning body essentially. But there is room for sort of specifically me to build upon what is in this plan and bring these principles sort of more into the plan. So I'm also really kind of hoping that people are going to have suggestions and ways in which I can sort of bolster, you know, what we're kind of doing here. Anyway, I need to move a bit faster through these slides. So safety. So in terms of building a sort of a safe space for people, we use that sort of that reception area to make sure that we are only supporting people who have been affected by that emergency or are part of people's support networks and family. Of course, that can be quite a woolly term. We let people sort of define that themselves, but basically we kind of only want to be supporting largely those who are affected. Maintaining a calm and sort of tranquil space is something that we train our emergency centre officers and managers to do. Conflict resolution and emotional support, that is delivered by the British Red Cross as well to all of our emergency centre staff. Safeguarding, safeguarding is mentioned in all of our training, making sure that everyone in the emergency centre, including our voluntary sector partners, knows what to look for and how to handle safeguarding concerns. I think is basically everybody's responsibility in these spaces. I appreciate that when we're talking about safety, not having media in a space doesn't necessarily kind of equate to safety, but I do think that the absence of journalists in these spaces contributes to that sort of that calm space, that feeling of this is a place of kind of sanctuary, really, that people aren't being harassed or being sort of requested to make statements. People, of course, can do all that, and we don't make any attempt to stop people from doing that, but we ask that it happens outside of an emergency centre. Trustworthiness and transparency. So for me, in an emergency centre, this largely boils down to information management. We always make sure that we have a message board so that we can make a kind of really loose like contract with people to say that information is coming at 0:00, 1:45, when the fire brigade get here, or whatever it might be, and we're kind of conscious that we need to stick to those small deals, because you're essentially asking people that, if you can sort of hang tight until this point, then we'll give you everything, all the information that we've got, and that information gets written up for others to see as well. I think it's also important that, like I say, if the kind of the control of information in the emergency centre gets away from the centre manager, the mood can be lost. People can feel like the council is withholding things, that we are being duplicitous, and so just really kind of addressing rumours addressing information vacuums kind of dead on are two really important things that we train our managers to do. There's also, of course, things around sort of managing expectations around, what we're saying to attendees as well, as you can imagine. Next, so these next two, I thought of like merging them together. I don't think I've separated them particularly well. So in terms of peer support, we usually try and sort of staff our emergency centres with people who, from all of the council, but if I can get people who have a social care background or kind of a background, in community work, then, we have people who are just perhaps have a few more of those skills. Trying to find people who have emergency experience isn't something that we've kind of explored just yet. Yeah, I've kind of touched on the emotional support that they offer. But yeah, I think this is perhaps an area that we or in this kind of space that we might be lacking in a bit. So perhaps we can expand on that later on. Collaboration and mutuality. So this part for me is all about bringing in, the voluntary sector and our kind of local community groups and our local voluntary centre as well. So we've got good links with the British Red Cross, with St John Ambulance, with First Aid Nursing Yeomanry, with Islamic Relief, like all big, formalised charities that work in emergency response, in providing support to people. So we're able to bring those guys into an emergency response to add capacity to us to support our residents. Okay. We've also got links into the London Communities Emergency Partnership. This would have just been awash with acronyms if I'd not cleaned it up before I came here, by the way.
Callum, sorry,
yes?
can you kind of moved into your Q&A time, so I just wanted to give you that heads up.
Sure. I realised
yeah.
I'm just a couple of slides away from that Q&A time. I'll be at another 2 minutes max. That's okay. Apologies, and thanks for the heads up.
That's fine. Yeah.
Cool. Yeah. So I think that we've got good links into our voluntary sector. We've got kind of growing links into faith sector. We've hosted trainings, resilience trainings with our faith leaders, some faith leaders in this borough. There's more work to be done there. There's a lot more work to be done by me on reaching out to community groups so that when these emergencies happen in parts of Tower Hamlets, there are local groups who have local understanding of the area, of the community, of the people that live there, and that we can invite them into this space. I can plug some of that gap with the London Communities Emergency Partnership, but that is certainly an area for me to expand on. Empowerment. Oh wow, this can do all this. This comes largely in the form of, this is the mental health first aid training that our emergency centre staff get. The empowerment element, again, a little bit thin on the ground, comes from that E in karma, enabling the service users' ability to cope, connecting them with friends and family and community. So in a nutshell, that's trying to provide a person-centered response, trying to listen to what the person wants and trying to enable them to be able to bring about that change that's going to begin their recovery and help their sort of response to this emergency. In terms of cultural, historical and gender issues, really need some suggestions on how we can how I can develop this space, to be perfectly honest. That does kind of bring me to the end of the slides, so I can sort of pause for questions as well at this point.
Thank you, Callum, for another excellent presentation. I'm sure there'll be ideas about that last slide, but really informative and really helpful, and very good to see how you're using the principles to thread trauma-informed approaches through this offer. Perhaps if you want to stop sharing your screen and we can take questions.
Sure.
Okay.
Covered it all. Perfect.
There's a lot to cover, but Lydia and Angela have got questions or comments. Lydia,
I guess it's just going to expand on what I wrote in the comment section. So I think my first thought all the way through there, and this is me partly with my speech and language therapy head on, but partly on my working in Tower Hamlets head, is just the language barrier to all of this. So I have no doubt, obviously, you've probably got quite a diverse staff force who would be on the ground anyway, especially with a lot of those local cultural link-ups. But just with that very immediate first contact where someone's coming into that reception area, actually being able to even give your name, your age, especially if you're here illegally, if you're in a large family, really silly things like not knowing what a surname, like what names you're after, what you're looking for, and just how you have something really safe, visual, that's not just relying on this talking, like name, age, where do you live, what do you do, like something that just instantly feels much safer, much more accessible, and also who's providing that information, because again, thinking about culturally who might hold most of that information, and just I think that would be one of those points where you've just experienced this huge event, and then how do you, like you already said, kind of how do you make this be as safe as possible? And I think that first contact feels to me like one of those areas that, from a processing point of view, it's getting people in, working out what they need, but actually that requires a really high level of communication. So even being able to say, what do you need? Well, I need my house, I need my clothes, I'm worried about this person, I'm on my period, I don't know, all these things. It's just it's a lot for someone to be able to kind of even think about, let alone then vocalize. So I think there's just perhaps some work you could do there to have some kind of materials that are I don't know, in plain English. So if they've got a phone, they can use to Google Translate, things like that. That I've got lots of pictorial information, that are big print, just some things that instantly feel a bit more welcoming and a bit more kind of, I don't know, that's speech language.
I see a bit of collaboration coming up here. I think you're offering resources. I think that's partly what this group is about, is sort of actually, I've got something that can help you with this. Maybe it's too much of an ask, but I think that would be fantastic. Elliot.
Thank you, Callum. Covered a lot of ground. Very, very good presentation. Thank you. So I guess one thing is just thinking about the staff, the people that are there. In a way, back to what Roisin was talking about, if the staff team don't feel supported, I know you talked about British Red Cross training, but these things could happen at any moment, and they might be taken out of other roles, I guess, or they're volunteers, don't know, but suddenly they're trying to provide support for a bunch of people that don't want to be receiving the support. They wanted to just be back at home. So part one is the staff support. What does that look like? How is it arranged? It's more than just the training, it's the ongoing support. The other question is about interface. So I have in this role been somewhat involved in one of the fires in the borough, and I think that then triggered, or prompted rather, I'd say, me and some other colleagues to think about what the interfaces between East London Mental Health Foundation Trust should look like with our colleagues in LBTH. So that is probably not a conversation for here, but maybe one that we catch up on, and I'll put my email in the chat so we can catch up at another time. Thank you.
Thanks. Yeah, I think that the welfare of sort of everybody's welfare, but in this particular context, like staff welfare, is everybody's responsibility as well. So I think kind of identifying, how an individual is feeling, asking your colleagues, that is an important thing to do in an emergency centre. In terms of, what support is on offer, there are the welfare is touched on in the training. I know I'm trying to solve all problems with training, right? But also it is there are like council-based services. So there is the employee assistance helpline. So that's a place where people can go online and kind of get a bit of emotional support from a sort of a mental health practitioner. So another thing that I do is I hold defusing and debriefing sessions with our emergency centre managers on a one-to-one basis, all optional attendance, to kind of go through and process how they are feeling, and to sort of have the conversation led by them as to how they want to kind of move through, you know, what we could do to how they're feeling, you know, moving forwards, essentially. There's also hot and cold debriefs that are done on scene, and a component of those hot debriefs is recognizing that everyone has, you know, given a lot and sort of supported the community, and this has been often they're quite sort of trying times for people, and then signposting to those extra support kind of elements that I mentioned as well. I think that beyond, you know, what's been said of looking out for each other in an emergency centre, accessing the formal council sort of employee assistance package, and the sort of the defusing and debriefing sessions that I've offered, I don't think there is anything else beyond that, but that's the stuff that we've got in place at the moment. But yeah, really keen to hear of any suggestions of any others.
So another bit of collaboration I see emerging.
Sure.
Angela, are you winding up, or
no, a small
Oh,
suggestion.
yeah.
Also, I put the link to the feedback form in the chat,
Yeah.
so please do complete that before you
Yeah.
head off. Thank you. Thanks, Callum. I really appreciate you also taking the time to reflect on your work, because I know that that's kind of hard for us to do when we're still at the beginning of that process. But I feel like there's a lot that you're already that you've already got in place, so that's really great. One thing, just going back to the principle around transparency and trust, I think it could be helpful to, I don't know if the plan is public, but I think perhaps one way to build trust is for people, like for more people to know what's going on or what to expect in those emergency settings ahead of time. So doing more of that with like resident groups and BCS organizations, so that it's like kind of a shared, like basically a more well-known expected plan. And I think that that can also be like trauma informed, in the sense that like not everything is a surprise when it's going on. And I'll link up with you after just around suggestions for who you could connect with. Like I know, for instance, we have a new like Somali center, or like Somali-led center, that could be a really good, for instance, place to engage with as a good connection to the Somali community.
Yeah.
Thank you.
Yeah. Really keen for that.
Sorry, another connection. I'm very mindful of time. I just wanted to put something in about the cultural aspect, and I think one thing to maybe think about, and again, happy to talk to you about this, is thinking about the local communities, and particularly ones that have a history of displacement and forced displacement in their collective memory. Thinking about our Somali residents, and also Bangladeshi residents, and, you know, thinking about partition, that some of those narratives live on, and so that sense of being forcibly displaced from your home might have that kind of resonance with wider cultural collective memories and trauma. So finding out a bit more about those stories, I think, would help with that piece.
Yeah, fantastic. Thanks. Yeah, really good idea.
Okay, I think we could have gone on for a couple of hours today. I think the two incredibly rich presentations, which I think we kind of possibly slightly iceberg-like, that we only really saw the surface. There's much more going on. I think it's always good if we can welcome you back when you're a bit further down the line. It would be great to hear about your learning and what next. So thank you, everybody. The evaluation form is in the chat. Please do take time to complete that, because that helps us keep our focus sharp, and hopefully kind of meeting what you're looking for out of this space. Our next session will be in August. I think we will plan ahead as if it's going ahead. I don't know that we have got people lined up for August. Angela, do we? No. Okay, so if anybody would like to present in August, then please do get in touch with Angela and myself, and we can think about that. And also, doesn't have to be August, it can be any month of the year. If you've got things that you want to share with us, we'd love to hear about what's happening. It doesn't have to be perfectly shaped. It can be what you're struggling with. It can be messy, as most of our work is, and halfway through. So do have a think about what you might share with the community. Okay, well, with that, thank you, and thank you very much to Callum and Roisin, and I look forward to seeing you in August. Thank you. Bye.
Bye bye. Thanks.